Well, good afternoon, and thank you for participating in a real-life experiment here of all your own flexibility and accommodation abilities to move from different rooms and split up rooms. For those of you who aren't aware of it, we have another room down the hall that's being teleconferenced in, as well as at the University in Harborview, so we welcome you all. I know we have a large crowd out there. We're very happy today to have the privilege of having Dr. Benjamin Druss here with us. This, in the Department of Psychiatry, is our major annual university presentation of historical consequence. Dr. Herbert Ripley was our first department chair, who was chair from, I think, about 1950, 49 or 50 until the late 60s. He was still here when I was a resident. No, it wasn't in the 1930s. It was in the 1970s. He ran the consultation liaison service when I was a resident, and actually had a substantial influence on the course of my career. He plucked me off and had me start a conference on psychosomatic medicine and taught me that I maybe should be reading literature and a few other things, and it sort of gave me my first exposure to academic medicine. So he's also a lovely, wonderful, warm man, and obviously there was a significant influence in trying to maintain his name and presence among us by establishing this professorship and this seminar, which we've been running for a very long time. Today we are very pleased to have Dr. Druss here, who's going to be talking to us about an area of substantial increasing interest nationally, certainly locally, as we look at healthcare reform, and finally, after centuries and certainly decades of segregation and marginalization and stigmatization of the chronically mentally ill in terms of how they're cared for, we're beginning to see now substantial forces coming to bear that's going to help us integrate care and provide a better quality of care for those among us who are, in fact, often the most needy and most deserving. So we're very fortunate. Dr. Druss received his MD at New York University and went on to Yale University, where he received an M.P.H. and did his psychiatric residency. He stayed there on the faculty for the early years of his academic career and moved in 2003 to Emory, where he was appointed the Rosalind Carter Chair in Mental Health and is now a professor of public health and psychiatry at Emory University. He's been a thought leader and a major contributor to the research and now early implementation activity, trying to integrate medicine and psychiatry in the setting of the chronically and seriously mentally ill. And he's going to talk to us today on improving health and health care for persons with serious mental illness. So please join me in welcoming Dr. Druss.
Thanks, Richard. Boy, it's so great to be here. I can't tell you. This is, as I was telling Richard and Wayne Caton over breakfast today, I was out here about 15 years ago, I think, presenting this was the first time I ever presented the results of the first study, which I'll kind of very briefly review here today on this topic that has become kind of really a focus of both my research work and a century, and it's been gratifying to see how this has moved on to the policy radar screen over the last few years, and became a focus in terms of getting a lot of issues around mental health onto the broader radar screen of health reform. So it feels like a homecoming, and it's so nice to be here with people who I know and respect, and get to kind of rethink about where we're at as in terms of where the field has come. So what I am going to do is talk, and I want to make sure to leave enough time in my talk to hear from you and to get your questions and thoughts on this. But I'm going to briefly define the problem context for the population of people with serious mental illness, even more perhaps than the general population. The stakes are really very high. So let me start just historically by bringing you back to the late 1920s, 1928 through 1931, where an epidemiologist in the New York State mental health system did a study in which he looked at all the people who had been inpatients in the state hospitals in New York and just compared their causes and rates of mortality to the general population in New York. And this is actually a methodology that's been used a lot in some of the recent studies that have generated some interest in this area, but this is something that really has been done at least since these first studies conducted in the late 1920s. And what he found is that people in the state hospitals of New York died on average 15 years before the average, the predicted death rate in New York State. And the mortality was due not to unnatural causes like suicide or accidents, but to what were then the same causes of death that were afflicting the general population, which were heart disease, pneumonia, tuberculosis, peripheral artery disease. And this is really the same of excess mortality in the population. There was one year that the National Health Interview Survey had a mental health supplement, and that was in 1989. And it's possible to look at linkage data with mortality in the subsequent years. And so we wanted to look both at the overall rates of mortality and then to try to tease out and say what's going on here, what are the possible contributors to the excess mortality, and looking at three broad buckets of factors that were available on the first survey: socioeconomic, health system factors, and some of the clinical factors that were going on. And what you see here, again, when you're looking, rather than comparing a public sector population to the general state rates, but looking within the same population, people with mental disorders died on average about 8 years earlier than people without mental disorders. And that's about, if you look at the top row, about a twofold increase in excess mortality, which is consistent with other studies that have been looked at across a number of different settings in different populations. Much of the work has actually been done in Scandinavia, where they have very good registries. But if you control sequentially for some of these different groups of factors, that gives you an idea of the role they might play in this excess mortality. So when you add in, for instance, socioeconomic factors like education and income, the rate drops from 2 to 1.77. If you add health system factors, so like what was available, at least in 1989, like rates of service use, primary care service use, similarly, the rate drops in this case from excess mortality from 2 to 1.8. And then clinical baseline factors, so what people's medical status was at baseline in 1989 was the most important, and the rate drops there from 2.0 to 1.3. And when you add all these three together, the rate actually drops the farthest, which you would expect, to 1.2, and becomes non-significant. So again, this gives sort of a global sense of some of the broad buckets of categories. I should say that one set of variables that we wish we had had that is clearly critically important are behavioral risk factors: smoking, diet, exercise. And these fit very nicely, and it's quite consistent with the same causes of death in the general population. It's been estimated that when you look in the general population, that behavioral factors, genetic predisposition, these social and environmental factors, and healthcare each play a role in determining excess mortality. You should note that healthcare isn't the majority of that. So improving primary care, which is, of course, the focus of my work and of a lot of the policy initiatives now, are important. They're necessary, but probably not sufficient to improve health in the population. You're going to have to look at all of these groups of factors. So when you look at public health, I like to think of it in terms of the different, sort of the old-style public health, different kinds of prevention. So primary prevention means you want to stop the risk factors before they begin, and this is thinking about whole population care. What can you do to improve the health of the whole population even before they become sick? Secondary prevention means you want to catch problems early through screening and early detection to treat them before they get to be bigger problems. And then tertiary prevention really is just another name for treatment, which means effective and early treatment in the course of illness to prevent the development of either mortality or disability. For the population that we're talking about, there's a lot of examples that are already going on in the community of work at all of these different levels. So primary prevention can mean things like making psychiatric facilities smoke-free, which for anyone who's been working in the business for a while, I mean, cigarettes used to be sort of the lifeblood, the token economy that ran inpatient units. Increasingly now, there's been a push to make inpatient facilities smoke-free. And I think, I don't know, in terms of like for Harborview here, is that?
May 31st, the whole institution is going smoke-free.
So this is the way that the world is going, and it took a little while for inpatient psychiatry to catch up, but I think that's essentially the sense is that this is really where things need to move. Community mental health centers are increasingly thinking in terms of just providing exercise facilities, access to either within the facility or within the community. So there's a program called In Shape in New Hampshire that links people to YMCAs and other facilities where they can exercise as part of the broader community. And there's other interesting programs around looking within the broader community in terms of diet and exercise. So in New Haven, there's a farmers market now that comes for a half day a week to the New Haven Connecticut Mental Health Center, and that where farmers can sell healthy fruits and vegetables both to staff and to patients who are there. This is really primary prevention. This is really thinking in terms of the whole population, regardless of whether they've yet have developed risk factors. Secondary prevention, as I said, is all about early diagnosis, screening, and treatment. And increasingly, there is a standard of care to screen people, particularly those on second-generation antipsychotics and other psychiatric medications that can contribute to diabetes and other cardiovascular risk factors. That's the standard of care, is to screen them. But again, the caveat is to keep in mind that, as with early efforts to screen for common mental disorders in primary care, like depression, screening isn't enough. It's just a first step. And we're beginning to bump up against that in a lot of community mental health facilities that are screening for cardiometabolic problems, but then don't yet have the wherewithal to actually provide treatment for people who screen positive. As I said, tertiary prevention is really just about providing effective care for illness. And I would be remiss if I came all the way out to University of Washington in Seattle and didn't show people a picture of the chronic care model, which has become kind of the most widely used organizing principle for how we think about the pieces and how they work that we need to provide good quality care for chronic illnesses. And that's kind of how I've organized my own thinking in terms of the different pieces that are important in terms of providing medical care to people in specialty mental health settings. So you need to, first of all, the patient needs to be engaged. They need to be activated. And activated means they need to be able to play an active role in terms of both managing their health behaviors, smoking, diet, if they have diabetes, needing to know how to do finger sticks, and also how to successfully navigate within the health system, to be able to advocate for themselves, to work within what's often a very complicated, difficult system to maneuver in. Information technology, I was just talking to a faculty member here, was talking about patient health records. Information technology is a tool to help facilitate other processes of care. It's usually not enough in and of itself, but it can be an important tool. Working with a prepared, proactive practice team. So this is a team that meets regularly with patients even when they're not presenting with complaints or problems, and that uses measured care, active measurement of target outcomes over time to make sure that people are getting better, and when they're not, adjust care appropriately, and then remeasures. And then reorganizing healthcare is, of course, the policy and financing context within which all of the care is happening. And that's, in that context, I'm going to talk a little bit about some of the health reform initiatives that are currently underway. I'm going to focus in on one aspect of how to engage patients in care, which is a lot of the work that I've been involved in, which is the role of peers. There's been a lot of interest in using certified peer specialists in helping consumers become more engaged in self-management and more effective in working within the health system. In part, I've just gotten involved in this area because Georgia had one of the first and the most active consumer groups. And so we've really partnered along the way to move some of their work from more general mental health engagement to wellness and health engagement. And we've been moving in tandem both in the research that I've been doing and in a lot of the activities that they've been doing throughout the state, the Georgia Mental Health Consumer Network. And these peer activities sometimes are happening more kind of in parallel to the medical system and sometimes more actually with peers as part of the treatment team. And both, I think, have an important role. So an example of this is a study that we did a pilot study of initially. We adapted the chronic disease self-management program for mental health consumers. This is the most widely used peer-led program for managing health conditions that was developed in Stanford by Kate Lurig. And we essentially said, well, this should be very relevant to use of people of improving health care in people with serious mental illnesses. Consumers, it's very consonant with the idea of recovery. It's very consonant with the idea of consumers, the sorts of group-based programs that consumers had already been using for mental health care. It involves 6 group sessions. It involves a concept of action planning. This is the idea of setting achievable small goals. Rather than saying, I want to lose a bunch of weight, you say, I'm going to walk around the block for 20 minutes for Monday, Wednesday, and Friday of next week. You estimate how likely it is that you're going to be able to do that, and then you check back in a week later with the group and let them know if you've been able to achieve that goal. So it's sort of similar to the idea of measured care, of what's happening on the provider side. It's about having always a very clear idea of what you want to do, of tracking that over time, and of monitoring your own progress. And the pilot study was small, but it looked like there were very promising outcomes that were similar in magnitude to those seen for people without serious mental illness. A significant improvement in patient activation, which as I mentioned, is a measure of people's sense of their own ability to effectively manage their own health conditions and navigate in the health system. They were more likely to have a primary care visit. And there were very positive-looking trends in terms of some of our more distal outcomes, like health-related quality of life, physical activity, and medication adherence. And we just found out probably about a week ago or 2 weeks ago that we'll have the opportunity now to do a fully powered study of this intervention within Atlanta, and it'll be conducted across 4 diverse community mental health centers, urban, suburban, and rural. And we'll be working closely with the Georgia Mental Health Consumer Network to roll it out and to staff it. They'll be essentially running the clinical intervention. I want to briefly mention information technology. There's actually, again, this is a program that is kind of rooted in Seattle, where we've adapted a health record that was developed in Seattle and are using it now for people with serious mental illness. It's a similar program that it has similar goals, I would say, to HARP, in that largely we are thinking of this personal health record as a tool for helping patients better engage with their own health care, to learn more about their health problems, and ultimately it may also be a tool that will help coordinate care across providers as well. The program that we're adapting, the personal health record, is called the Shared Care Plan. Unlike many other personal health records, this was actually developed to be used in community settings. It wasn't an extension of an electronic health record or medical record. And it was developed in Bellingham, Washington, and is also being used right now in a pilot test in Harborview. This is what our adapted version looks like. It's called My Health Record. Largely, it's more similar than different to the original health record that was developed. We added in a program for advanced mental health directives to the health directives. We did a lot of training. A lot of what we needed to do in the adaptation was less about changing the record than helping patients be able to better use it. So all patients get computer training to start off with, not only around the use of the health record, but more general computer training. And it's administered with a registered nurse who works essentially as a health educator to help people use it as a tool to learn more about their care and to engage better with their care. What we're eventually going to do what we are doing in the evaluation is a randomized trial that looks first at people who have the record plus the nurse care manager versus usual care for people with one or more chronic medical condition and serious mental illness. And then we're going to also track people for 6 months afterwards to see if they continue to use the record and continue to have benefits without the use of the care manager. So we're trying to disentangle the effects of, in this case, an information technology intervention that really is a tool for improving clinical care from the effects of just having the technology on its own. So finally, we've talked about activation and kind of engaging patients more effectively in their care. I want to talk a little bit about different models of actually improving primary care for the population. And there's essentially 3 different approaches to doing this. One is you can bring care on-site through a fully collocated model, which is probably the most intensive approach. It's the one that is the most close probably to some of the collaborative care models that were developed here for depression and primary care, which were collocated. There's facilitated referral models in which you link people back to any place where they can get medical care in the community. And then an approach that I think is getting more traction now increasingly in the community, which are partnership-based approaches, where you take a community mental health center and pair it with a medical provider, commonly a federally qualified health center, and develop kind of a virtual medical home that spans across the two organizations. And I'm going to talk about some data from each of the three kinds of models, but really all are being used in all are appropriate ways depending on the particular system that you're working in for improving medical care in the population. So this is the study. It's not the exact same slide that I used, but this is the study that we were working on 15 years ago when I was here at the University of Washington, and that was published in 2001. This was in a VA clinic, which is probably the kinds of sites, VA or staff model HMOs, where these fully co-located models are most practical to implement. We provided all medical care within a mental health clinic through a multidisciplinary team, and basically just had on-site medical care fully provided for the patients in the mental health clinic, provided by a nurse practitioner, supervised by a family practitioner. And the results in that case, our primary outcome at that point was the physical health component summary of the SF-36, which is a measure of health-related quality of life. It's a general measure of health status. And what we found was a significant spread over time, by 12 months, significant improvement relative to usual care in this overall physical health. So that gave us a sense that, it's promising. Actually, you improve people's medical care and they get better. We then did a study which just finished, and we've presented we published the 6-month results, and I'm going to present, the 12-month results. I'm going to present to you the 2-year results and also some cost findings of a referral model. And this is essentially a stripped-down, bare-bones approach to improving care in the population, which says if you're working in a community mental health center, what's the sort of simplest way that you can get people better medical care? You can retrain essentially care managers who are already providing helping people link to better mental health services and to community services, retrain them to provide medical education and also linkage to medical services. So this was a model in which we hired a medical nurse care manager and also a mental health care manager, and their goal was to improve primary medical care for this population. And essentially they did this through a mix of education and activation around their medical conditions, and then also linkage out to care in the community. And their task was to make sure that people got the preventive primary care services that they needed, whatever it took. So this it was very flexible in terms of the sorts of activities that they did, compared to the personal health record study, in which primarily they were helping patients to link to care themselves. They were very active in the PCARE study. So they went out, they would accompany patients to meetings, they would call up doctors, they would make appointments for patients. They were very active. And again, what we found is that improving using care managers has improved quality of medical care. Preventive services stayed essentially flat in the group that didn't have PCARE, and over 1 year and then staying steady over 2 years, the use of preventive services more than doubled to greater than 50%. And that was our primary outcome, was just looking at, do they actually get better care? Interestingly, when we looked at the subset of the group who had cardiometabolic risk factors, high blood pressure, high cholesterol, or diabetes. We also saw a spread over time, and by the second year, there was actually a significant difference between improvement in the Framingham score. This is like an aggregate kind of bottom line score for your likelihood of having a coronary event at 10 years. And we saw a significant improvement, a significantly better Framingham score, lower risk of a coronary event at 2 years for the PCARE group compared to the usual care group. Interestingly, in this case, we did not see we saw a trend towards an improvement on the physical component summary, but not a significant improvement. What we did see, interestingly, was a significant improvement over time on the mental component summary of the SF-36. And what you see is the greatest improvement in the first year, and then a continued sort of parallel persistence of the change over 2 years. We recently completed a study looking at the costs of the program. And what we did here was try to look at the costs from two different perspectives. We wanted to look at the cost from the perspective that's typically looked at, which is the societal perspective, which is overall, on balance, what were the costs of the program? Is this sort of a good deal for society? And that was what we looked at first. And what we found was, yes, actually, but although during the first year, costs for the program were a little bit higher, non-significantly higher for the PCARE group than the control group, by the second year, what you saw is that overall, when you add up all the costs, the case group, the PCARE group, actually had lower costs than the control group. The probability of a cost offset, if you looked across the whole group, was over 90%, 92.3%, and if you actually trimmed off the outliers, it was 96%. So what you see is, from a societal perspective, what it looks like is this relatively cheap intervention, care management, seems to result in decreased use, and it was actually use across almost all of the domains of cost, both on the mental health side and on the medical side. You saw reduced costs from a health service perspective. But the problem with the societal perspective is that it's largely irrelevant in terms of how managers think about whether they should start a program or not. So what we tried to do was a managerial perspective, as to sort of look at this another way in terms of how things actually happen in the real world. From a managerial perspective, what a clinic manager looks at is whether the revenues that are going to be coming in from a new program are enough to pay for the expenses of a program, which in the care management setting is largely the cost of hiring the care managers. And what you find from this perspective is it is highly dependent on the revenues that are flowing in. And that is highly dependent on whether patients have insurance or not. In the community mental health center that we worked in, uninsured patients basically, received there was almost no reimbursement for uninsured patients coming in. That was sort of came out of the hide of the state block grant that comes into the community mental health center. Medicaid patients, on the other hand, are a better deal for the community mental health center, and more generally, for evidence-based, for any new program that's being started up, it's more feasible to capture the revenues and to pay for new programs that are being started. And what we estimated is that had the clinic had at least 50% of the clinic had Medicaid or some other form of health insurance, this program could have been revenue neutral, paid for itself, broken even. Unfortunately, at least in our clinic, only about 40% of the clinic had Medicaid. And so the program wasn't financially sustainable after the study ended, and it closed down. And to us, this really spoke a lot to the broader issue of why evidence-based practices, even when they are, from a societal perspective, cost-effective, sometimes even cost savings, aren't financially sustainable under routine conditions of how health clinics actually have to bill for services. And it also spoke for the potential for health reform with expanded insurance, expanded populations being covered either by private insurance or Medicaid, to help fix this problem and make it more viable for clinic managers to start up other kinds of programs in which you need to have enough revenue coming in to cover the cost of paying for staff, basically.
And for the health care for the uninsured people.
Correct.
So who is paying for it though? How are they getting it?
Well, the state generally, and I don't know, I would defer to an expert on this in terms of how it works here, but in Georgia, there's a block grant that filters through the states that to individual community mental health centers. That's an annual block grant that comes in, but that is not dependent on the services that are being provided. So the incentive there, they're getting the block grant based on the total number of patients that are enrolled in the clinic. I'm sorry, that are enrolled, yes, that are treated at the community mental health center. But there's a disincentive to start new programs, which cost more per patient.
If they are getting their mental health services paid for by this black grant, how are they getting their medical services paid for? That would be covered in that black grant.
It's not broken out that way. The community mental health center just gets a flat amount of money, basically.
I understand that, but
Yeah.
I understand if I'm a person who
Sure.
I have no insurance, but I can go to the mental health center because the block grant covers that, how do I then go to a physical health care provider and get services?
How could you go outside?
Right, if I don't have.
You're right. I mean, so this is talking about paying for the care managers, and you're saying how would you get your other medical care? Well, again, one of the reasons that federally qualified health centers are sort of the favored, often partners in these partnership models is because they're one of the few kinds of organizations that takes patients regardless of their ability to pay. And they get money from the Bureau of Primary Health Care. They get grants also that are based on the number of patients that they treat. So that's the safety net, and that's sort of the focus of where much of our work is happening. On the mental health side, the safety net is community mental health centers, and largely on the medical side, it's federally qualified health centers. Well, I want to move kind of quickly through the rest, but a study that we're working on now is called the HOME study, which is one of these partnership-based models in which a federally qualified health center has set up a satellite clinic, is setting up a satellite clinic within a community mental health center. And this actually has, there are a lot of benefits to this sort of model. Federally qualified health centers can actually bill at higher rates and are better equipped to care for uninsured patients. They have favorable rates for getting discounted pharmaceuticals. They have a lot of benefits even compared to community mental health centers, and this seems to be a very viable approach if you're able to blend these two organizations. And it's probably the most commonly used method now for establishing medical services in community mental health centers. SAMHSA, which I'll talk about briefly, has a program now, a grant program that is setting up to improve primary care services in community mental health centers, and probably the predominant approach that's being used are these partnership-based models, typically with federally qualified health centers. In our study, we're focusing on patients with cardiometabolic problems. We have a physician assistant and a nurse care manager. They are employees of the FQHC. They're not research staff, and they're providing all of the health care for these patients. And we're using electronic health records also to create a virtual medical home, essentially spanning these two organizations. And much in the same way as Wayne Caton did in the team care study and has been doing in his earlier work, and that Jürgen Unitzer has done in the impact study, measured care is a very central component of this. You look at the outcomes, in this case, diabetes, high blood pressure, high cholesterol. You track it over time. If they're not getting better, you change something. and this has really been a fascinating study to do, just in terms of working across two organizations, trying to understand how each of them works and to create a model that works across these two systems. And actually, they've developed, even outside of us, we sort of helped create this marriage across an FQHC and a CMHC in Atlanta. And they've continued to work in parallel to our study in their other clinics. They've created similar clinics, and they have one of those SAMHSA grants now. So it's been, yeah, it's been really a fascinating process and fun. So I wanted to spend a few minutes talking about this broader issue of healthcare reform, because there's so much that already has been going on and that will be going on, just because I think this is going to continue to move the ball forward in terms of the health status of people with serious mental illness. The biggest piece of health reform is expansion of insurance, particularly Medicaid. And Medicaid, as we all know, is just critical for the population that we treat and is likely to become even more important over time. There are medical home demonstration projects that I want to briefly talk about, the SAMHSA integration program, and then just a reminder about prevention and promotion. Medicaid, one of the most important changes under health reform is the expansion of Medicaid to the near poor. It's been expanded to 133% of the poverty level. And after health reform, Medicaid is going to cover about a quarter of people with serious mental disorders versus about half of that, 12.4% pre-reform. So however important Medicaid has been to our population before, it's just going to be absolutely critical after health reform is enacted. And this is going to be an increase of millions of users of mental health services in Medicaid, as well as in private insurance. There's a lot, there's going to be a lot of challenges in this. I mean, the system is going to have to absorb all of these new patients, of course, and the workforce is likely not going to expand in proportion to all of these new patients who are entering the system. So there's going to be a lot of challenges, I think, that systems are going to have in terms of absorbing them. But ultimately, I think it's going to be good for safety net systems, who, as I described earlier, will hopefully fare better under having more Medicaid-insured patients than they have now, and also for our patients in general. Medical home demonstration projects are also going to be a central part of health reform. These are happening both under Medicare and Medicaid. And they're happening also for dually eligible patients. I just heard, I think yesterday, that very recently Washington was awarded one of these demonstration projects for dually eligible patients. I don't know where you're at in terms of your Medicaid medical home demonstration projects, and whether, do you know, has the state applied for one of those? I assume it has. And really, thanks to a lot of this work that had already been going on and very effective advocacy, mental health is very much a part of these Medicaid demonstration projects. The language for these projects explicitly includes people with serious mental illness as the target population. You either have to have two chronic medical conditions or a serious and persistent mental illness. And community mental health centers can be sites for these medical homes. So this is just, huge for the field, and is so different from how it would have looked if healthcare reform had been enacted 10 or 15 years ago. There are these grants administered through SAMHSA. There are 56 of them now that are providing resources for community mental health providers to provide healthcare and wellness services. And they fund primary care services, referral costs. The idea is of these grants that they're supposed to fund this stuff that is hard to fund to be reimbursed for under Medicaid. And the goal of them is really to be sustainable at the end of the program. So a number of them have been funded. The National Council for Community Behavioral Health Care, which is meeting as we are meeting here right now, is helping provide technical assistance to these programs to help them get up and running. So, and this is also going to be important for the field, just looking at how these models can be implemented and how incredibly variably these models are implemented in real-world practice. RAND is doing an evaluation of them. Originally, they were going to try to look at the different models to see which ones were more effective or less effective, and what they found was that of 56 different sites, there were almost 56 different sorts of models, and so they had to kind of change the questions that they're looking at. And again, that speaks to just how messy things get when you try to implement these sorts of programs in real-world practice, and how little sometimes we researchers have to actually offer the field when people are trying to do these under the very complicated conditions of real-world practice. Finally, I just want to emphasize the importance of this issue of prevention and wellness. Health reform, as of today, includes a national strategy that's going to support and expand health prevention and wellness. If we're ever going to tackle this problem of premature mortality in the general population, and particularly in vulnerable populations, including people with serious mental illness, we're going to have to get upstream. We're going to have to think about those primary and secondary prevention kinds of questions. Probably of all of health reform, this is the most vulnerable piece. The House has already passed specific resolutions defunding this part of health reform, and it's very vulnerable because it's probably you see the benefits of prevention and promotion accrue down the line. You don't see them right away, so it's easy to take money away from it. And more generally, of course, the whole fate of health reform is at this point not completely certain. The House has passed a bill repealing health reform. Hasn't been passed by the Senate. Large pieces of it may end up being defunded, but a lot of it probably won't be, and a lot of the regulatory elements have already been put in place. And furthermore, a lot of the stuff that I'm talking about has really taken on a kind of grassroots quality. A lot of these integration activities are happening and are likely to happen regardless of the fate of health reform. So in part they were spurred by people anticipating health reform. In part they've kind of grown up just kind of almost in a grassroots way. But I think a lot of the sorts of changes that I'm talking about are likely to continue regardless of what happens to health reform. And so, who knows what's going to happen? This quote, it's not even clear that I was trying to read about this quote, and apparently it's not even clear that Niels Bohr is the one who came up with this, but it's been attributed to many, many different people, including Mark Twain and Niels Bohr. And I think the key message for all of us is it's very hard to know exactly where things are going to be a few years from now, but a lot of stuff is already happening, and there's just, given all of the flux, I think there's real opportunities to try to change things at the community level. There's also a huge amount of opportunity just to study this and try to figure out what are the best ways of doing this. But in all likelihood, the research is going to have to continue almost playing catch-up to all of the activity that's going on right now in the communities. So, it's an exciting time to be doing this work, and, it's been a privilege to be able to be a part of this. And, I leave it to all of you able people who are out there to actually continue to make things happen, because I think it's a real opportunity to change a problem that has been around a long time. So, thank you.
We have time for questions.
Yeah.
There was a study just reported, I believe, this year in Scandinavia where they looked at people that were on neuroleptics and were not on neuroleptics, and the average age of death for people with schizophrenia was about 49 or 50 for both, and the folks that were treated, the ones that lived longest were on clozapine. Does that tie in with your sense of getting care and getting monitored?
I haven't seen that particular one. I had seen some studies that seem to suggest you're saying that clozapine had greater longevity, perhaps was protective against suicide, or it's I've seen other studies that have shown that that have looked and I've also seen studies that have shown, first of all, before even neuroleptics were used, that there was already a gap in mortality. Well, for instance, the study that I showed you from before. it's not clear, I mean, exactly what is the role of neuroleptics in mortality. Certainly one might expect that it would, if it helped people to be more organized, I suppose, and helped with the rest of people's lives, I suppose it might decrease suicide rates. I don't know. What do you think?
Well, the authors thought it might be because they monitored people, not so much that they weren't closing.
Oh, that's a really interesting point. Yeah.
They had to go for blood tests every couple of weeks.
That's a really interesting point. Everyone hear that? So it just shows how complicated it can be to try to tease apart these different factors. I think that regardless of the research, I mean, the messages are pretty clear, right? People should be monitored pretty carefully. They should get good medical care. They should get good mental health care. I mean, no one is saying that even in the case that second-generation antipsychotics are contributing to cardiometabolic risk factors, that means that everyone should immediately be stopped on all medications. Clearly, you have to look at the whole picture. I should say that increasing my own thinking in the area is trying to move past thinking of integration as just sort of mushing together medical services and mental health services, but really is about thinking more globally from a patient-centered point of view. What do people really need? And I think they need good medical care. They need good mental health care. They need good housing. They need hope, right? I mean, this is all important, and I think as I've been kind of marinating in all these issues for a number of years, I'm increasingly coming to think that you have to look more globally, and you have to get past just thinking of integration as being the only solution. Yeah?
So it's always hard to look at cost analysis because, as you know, often the cost saving is in ER visits or
Exactly.
patient stays,
Yeah.
and that cost savings never goes back to the clinic that hired the nurse that made it so the person didn't end up in the ER. So that's
Right.
where these always sort of
Right.
lose hope. But looking at the models you've looked at, if you were to look at a mental health clinic, what would you say would be the most cost-effective thing they could do? What would be the cost of hiring this person
Yep.
for helping the patient the most and also for perhaps decreasing costs the most? What would be...
You might repeat the questions.
So a couple of issues. I mean, you were talking about the problem which economists call externalities, which I love because it's so cold-blooded, but of the fact that often cost savings don't accrue in the same place that, to the same person or the same institution that started the program. I really am a believer that there's not a one-size-fits-all model. I think that heterogeneity that we're seeing across clinics, that we've tried to do across different studies, isn't a matter of a horse race, and that one model is ever going to be the right one that all clinics should do. I do think that care management models, part of the reason that we found possibly some cost savings, at least from a societal perspective, is just the fact that it's a cheap model to use to start off with. So it's simple and cheap. So it's an easy incremental model to start with and relatively inexpensive. Now, we'll be looking at our more intensive model, and I know that Dr. Caton is looking at the same issue for his team care model. And there, what you would expect, what you would hope for, is that a more intensive model may be more expensive, but also may even, result in a favorable cost profile as well. But I also think that it's just very important for local sites to understand their own kind of payment schemes and what's going to work for them and what they can make work. Because I very much believe that so long as you have the basic ingredients of good care, measured care and communication across providers, that almost any of these approaches is going to be a lot better than not doing anything at all. What's important is keeping in mind, again, and this applies also to depression in primary care or treatment of any common mental disorder in primary care. You want to have the key basic ingredients, but then local sites need a lot of freedom to innovate around that. And then they probably should track what their costs are. And if you're thinking of implementing a program like this to see what'll work, it's going to be important for you to be able to make a business case to whomever it is that is allowing you to do that. And I think it's important to track both, what outcomes you can track and also some simple cost metrics and to understand whether this is working for you. I don't know if that answers your question, but I think in the end it's going to be important. I don't see any of these approaches that we're doing, for instance, as, they're just examples. They're like stakes to the ground of different sorts of approaches that can be used. But I think in the end, what's going to be important is to leave local places with the freedom to kind of figure out what works for them, and that includes what works from a financial perspective.
The reason I'm asking is we
Yeah.
have a SAMHSA grant, so
Oh.
we are in that system. But
What are
we
you
have
guys
to-
doing?
So we're
How are you?
we're doing the intensive primary care in the mental health center with the dynamic nurse coordinators and peer counselors. So we're doing everything.
Right.
So, but it's not going to. We can't maintain that. It's just funding stream
Right.
will not allow us to maintain that as long as nursing visits aren't reimbursed, as long as peer counselor groups are not reimbursable, sort of things.
They're not reimbursable in Washington. They are in some states, so you should advocate in the meantime. Use some of your money to pay to go to Olympia.
That would be no extra money to do. So anyway, so I'm thinking long term, we know that this is a great model. We know it's not sustainable. But what can we learn from other places as far as what is probably, where should we put most of our money and what we do want to sustain after this?
It's such an important question, and I think it's such an important question for the technical assistance group to really be starting very early to think with sites about is which pieces of these are going to be sustainable and what are the ways that these are going to be able to be continued. Because I agree, even though the SAMHSA grants are more real world than a typical NIMH grant, I do fear that at the end of the 5 years, a lot of sites are going to be left with a difficult time. It's hard because they just will have had the money to start off with. I know that Kathy Reynolds, actually, who is the director of the Technical Assistance Center at SAMHSA, sort of prided herself on the fact that she would do these things without any resources when she was doing them in Washita County. And there's almost, in some ways, an advantage when you sort of are forced to do it without the extra money because it forces you to sort of put something together that can be sustained over time. But it's a hugely important question, and I think it's going to be incredibly contextual in terms of what you can make work and figuring out along the way what are the pieces of this that you can get paid for and how you're going to sustain those and then how you're going to kind of fill in around the edges to the pieces that can't be. And I'm sure I'll have more to learn from you on this than you from me, but I would like to hear how it goes. So.
And one of the consequences of our healthcare system and specialty-driven care has been their training has also been pretty segregated.
Absolutely.
As we move toward medical homes and hopefully more integrated care, beyond the impact of numbers of providers we need, can you comment on what you expect or maybe what we should be anticipating in terms of training the workforce?
It's a huge issue. I mean, there are provisions, I believe, in health reform to have better training for people in integrated care and these models. As you said, I think one issue is just going to be getting enough people out there who can do this. But to me also, if one of the lessons that I've learned from reading the literature on depression in primary care is that education and training, while important, is less important than what happens once people make their way into practice and creating environments where people can practice the way that they need to be able to practice. So training up front, I think, is really important. And actually, the Carter Center mental health program had a whole summit about this and what do we need to be able to train the new generation of providers, both in integrated care, but more generally to be able to provide sorts of primary care services that should be happening. I do think that there needs to be as much attention to what happens after people get out of training, how to keep them, first of all, through continuing medical education, just sort of the knowledge base, but also to create environments that allow them to practice, to do this sort of integrated care where that's the default. Because you can have the best trained people who come out, bright-eyed and bushy-tailed and ready to provide integrated care, and once they make their way out into the real world, it's really all about the system that they're working in. So I think it's critical, and I think we just have to think of training in this broader way of what that means to nurture a workforce that will be able to provide this sort of care.
I think we should probably stop there.